Okay, good afternoon, everyone. I think we've still got some folks joining us, but we're just going to do a brief introduction and then we'll get going. Thank you for joining us for the Healthy Transitions Colorado April webinar. My name is Kristen Paulson. I'm with the Center for Improving Value in Healthcare, and I'm really happy to be here with you as we discuss care transitions and home healthcare. Civic is the managing partner for Healthy Transitions Colorado in collaboration with our partners CFMC, the Colorado Hospital Association, the Colorado Healthcare Association, and Colorado Rural Health Center. Healthy Transitions is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions of care for all Coloradans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across specialties, facilities, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for the campaign follow the triple aim. Over 2 years, we hope to reduce 8,700 readmissions, or eliminate 8,700 readmissions, eliminate over 34,000 days in the hospital, and save over $80 million for Coloradans. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take that pledge and to learn more about Healthy Transitions Colorado, you can visit our website at www.healthytransitionscolorado.org. So just a couple of things before we get started. The phone lines have all been muted. We're going to keep them muted throughout the webinar. We're going to use the chat feature that's in the lower left-hand corner of your screen for questions and for any comments you have on the discussion. Questions posed to the presenter will then be answered during the question and answer session at the end of the presentation. The webinar is being recorded and is going to be posted to the Healthy Transitions site, so you can access this information again at any time for no cost. I'm now going to turn the program over to Maria Oren. She's the administrator of Angels Care Home Health. Maria has 18 years in healthcare administration, business strategy, and marketing leadership, and we're very pleased she was able to join us today. Maria? It would help if Maria, are you there?
Okay. Hey, Maria's doing a presentation on CFMC, so I'm going to hurry up and get off if you just choose
Maria?
for the entire region right now. Are you there?
Yes, okay. There's 2 people from your organization calling in on the same line.
Oh, that's fantastic. Okay.
Great, go ahead, Maria. Sorry about that.
Well, good afternoon, and I want to thank Healthy Transitions of Colorado for inviting me to present today. I am very honored and privileged to just have this opportunity. As you can see from my initial slide, this is about conscientious healthcare relationships. The original interest was how can home health improve our outcomes, and this is, I think, really going to kind of lead us to a conversation of how home health really does impact everybody's outcomes. Okay, there we go. And so who is this person? Well, my name is Maria. You won't get it right first 300-400 times, and that's okay. But I am a passionate administrator, have been for 18 years. I am with Angels Care Home Health, serving the greater Denver metro area. We have offices from Greeley to Westminster through Aurora, and we serve all the way down to Castle Rock, where we have another office in the Springs that picks that section up and manages patients all the way to Pueblo. But my true passion is truly to continue to learn, educate, and grow personally and professionally, and try to ignite others to engage to help move that needle across the spectrum. Our mission is to advance excellence through innovative home health services, provide positive home health outcomes and best practices among leading healthcare providers, thereby helping to improve the effectiveness and efficiency of our healthcare system. Or better served, and it fits on a business card, we serve patients. That's truly what we're trying to do at the end of every day. During this next hour, we will be discussing the history of the Patient Affordability Care Act and value-based purchasing, the changes in reimbursement, and how the shift in accountability of partners in care will directly affect outcomes efficiency, and ultimately impact reimbursement under Medicare. So historically, patient care has been delivered in somewhat a horizontal integration system. Each party offering patient care services were completely independent of the other provider's care, not responsible for the prior party's service. In a silo system of care, patients would rebound back to the hospital for multiple reasons. And in being in home care and historically hospice, some of the examples might have been, and this is just a random example, but a patient enters the hospital with pneumonia and UTI with symptoms of dizziness and history of falls. Patient discharged home from the hospital as they did not have a 3-midnight stay activating the rehab benefit under the Medicare. Home health was ordered. Patient sent home Friday afternoon. Home care would arrive on Saturday morning or afternoon, only to find the patient on the floor. Patient did not receive walker or wheelchair from DME company timely, no fault on their end, just that's how it was going, and became dizzy and fell during a transfer and injuring arm. Patient is then sent back to the hospital. Before 2012, this was a very common practice, and no one really took accountability for this situation. Today, under the Affordable Care Act, everyone is accountable and responsible for the delivery of care and how it impacts the hospital readmission rates. The silo effect must be absolutely erased, and transitional care delivery must be perceived by all as one system of care. Thus, the birth of the generation of vertical integration of care delivery, which is where Medicare is really encouraging us to go. Policymakers are constantly searching for ways to improve the quality of patient care and lower Medicare program spending. One indicator of inadequate quality that results in increased Medicare spending is the rate of readmissions to a hospital. A readmission refers to a patient being admitted to a hospital within a certain time frame from an initial admission. In the context of Medicare, readmissions have been generally defined as a patient being hospitalized within 30 days of an initial hospital stay. If a hospital has a high proportion of patients readmitted within a short time frame, it may be an indicator of inadequate quality of care in the hospital or a lack of appropriate coordination of post-discharge care. Although not all readmissions can be prevented, research does show that there are strategies that hospitals can employ to avert many readmissions. And according to CMS, about 1 in every 5 Medicare patients discharged from a hospital are readmitted within 30 days. 1 out of 5. That's terrible, but that's the truth. And that's what the truth we have to live in. Readmission rates vary substantially by hospital, by geographic area, even after the type of disease and the severity level of the patient's conditions are considered. Readmission rates are generally higher for hospitals, of course, serving vulnerable populations. The 3 scoring tools are now driven home by all members of the care delivery team. Patient satisfaction, outcome scoring, and efficiency are the majority of the reimbursement in 2014. Care delivery by all parties will directly impact the prior patient's care team's reimbursement. And we'll explain that a little bit in the future slides. If a patient has returned home with home care from a skilled nursing facility setting, and home care sends the patient back to the hospital within 30 days of the discharge from the hospital stay, this not only impacts the hospital reimbursement if it's still within the 30 days and the rehab only kept them for 15, but the SNF's outcomes as well. And of course, the home care agency will also suffer. There are many factors that affect readmissions, including patient's diagnosis, severity of illness, patient behavior, such as adherence to a discharge instructions, being willing to have a home care follow them, and the availability and quality of post-discharge care. Some readmissions may be planned, such as follow-up surgery or rehabilitation, or the result of transferring a patient from one hospital to another. There is no clear consensus on how many readmissions may be really preventable. Indeed, conclusions by various studies have deemed the proportion of readmissions that may be preventable anywhere between 5 to 79%, pretty wide spectrum. An analysis of 2012 Medicare claims, data by the Medicare Payment Advisory Commission, or MedPAC, concluded that about 3/4 of readmissions within 30 days were really potentially preventable, representing an estimated $12 billion in Medicare spending, which was unnecessary. Patient satisfaction scoring, outcome scoring, and efficiency scoring is the new standard of reimbursement to every Medicare service recipient. Having a very clear understanding of these three measures will greatly impact your processes and transitioning your consumer into the home setting, either independently or post-rehab. Excuse me. This table represents the changes in reimbursement that are currently in play. The old way of reimbursement was based on, quote, how processes, unquote, were delivered in the hospital systems for the past, 20 years. So it was really how the processes and efficiency in the hospital, that's really dictated their reimbursement. So if you look at the 2012 and 2013, 70% of the domain weight under processes of care, and there was 12 measure counts, 70% of their paycheck was focused on how they followed the protocol and processes per patient delivery within the hospital setting. Now, the weight is only 20% of reimbursement, with HCAP scores and outcomes are how care is delivered, and if the patient returned to the hospital setting within 30 days, along with the efficiency standard. So the weight has shifted from 70 to a meager 20% on processes. That means 80% of the reimbursement is now centered on performance outcomes and efficiency quality of care delivery. It would be as if I were the CEO of a hospital setting and handing our checkbook over to the skilled nursing facility or over to the home health and asking us to manage it. That's really what they're doing. My reimbursement, the CEO would say, is directly tied to the delivery and efficiency of the next partner in the care continuum. So the good news is the ACA continues a number of provisions intended to improve quality and reduce spending in the Medicare program, which may have the effect in reducing preventable readmissions. One of the provisions establishes the HRRP to provide a financial incentive for hospitals to reduce preventable readmissions. So beginning in fiscal 2013, the HRRP imposed a financial penalty on hospitals with excess of Medicare readmissions. The shift is from processes to performance, and those that perform well will also be rewarded financially. So this slide always overwhelmed me because I'm not that equipped with a DRG based on a wage and labor and share code. Those are things that I'm not really looking at, but I guarantee you the hospitals are. So if you're a hospital with low performance scores and high rehospitalization rates and flat outcomes, your reimbursement will be reduced by a minimum of 1% of your DRG per diagnosis. However, the same amount of care must be given to the patient to ensure outcomes. As we see in the new model, something must give. Length of stay may be compromised. This is just one diagnosis. Imagine the complications with multi-diagnoses, additional tests, labs, extended stays, empty beds offsetting the cost of the other reimbursement for the patients that are in the hospital, and how all of that will reduce the revenue from these hospitals. So CMS began applying the excess readmission penalties to hospital payments on October 1st, 2012, based on Medicare hospital data from 2008 through 2011. More than 2,200 hospitals were penalized on an aggregate of about $280 million in Medicare payments because of their excess readmissions. In the second year, which began October 1st of 2013, CMS estimates that 2,225 hospitals will be penalized around $227 million because of excess readmissions. This will not end anytime soon, and aggressive strategic steps must be taken to ensure long-term viability will be met. An example of the impact of these penalties is a local Colorado hospital recently had to pay back Medicare $1.8 million for the month of January. That's 1 month. They had an 18% readmission rate. So strategies are already affecting and impacting our local hospital economies. So as you can see, Medicare is adding increased rates to these penalties for readmissions and will significantly reduce and tighten processes taken by providers to ensure better outcomes are delivered. Hospitals will either improve or face severe consequences. The hospitals with very low readmission rates will be rewarded, as they will more than likely receive the reimbursement monies back for performance. So the incentive for the hospitals are to have the lowest reimbursement rates, better outcomes, and tight processes with every patient transition into a post-acute care setting. The challenge for each hospital will be to select and partner with the hospice, palliative care, skilled home care, non-medical, that can complete best practice and hold the lowest hospital cost per patient initial post-discharge 30-day episode. This choice will directly impact all future reimbursement to the hospital. So, I'm kind of a graph person. I like this slide because this makes sense to me. I like pies. Pies are good. So when I look at the value-based purchasing weight domain, you can see how the new shift in reimbursement directly has impacted how we do business will improve or not improve the outcomes of efficiency with the hospital or the skilled nursing facility. So as you can see, 80% of the reimbursement will be directly related to how care is delivered. Did the patient's home care start service timely? Was the patient treated with respect? Did the patient feel they were communicated with regarding all disciplines scheduled? Was the care given in a way that was compassionate, friendly, and courteous? Was the PCP notified timely of any changes or concerns regarding the patient? Was there superb communication through the continuum of care back to the rehab, not just at admission? Did the home health refer the patient back to the skilled nursing facility setting if changes occurred to bypass unnecessary ER visits? As you can see, much of the outcomes have shifted from how a process was completed within a hospital or skilled nursing facility setting and how care is delivered through the continuity and the continuum of it to ensure safety, care coordination, and transition back into the home seamlessly. You know, for those not prepared, this may seem a bit depressing and definitely daunting. So now in 2014, if you can see the blue slides, you can see that they've added two new measures. Medicare added two new measures that are added to the formulary of accountability, which means even less wiggle room is given to these hospitals' reimbursement. More emphasis is placed on efficiency and accountability to tighten processes, streamline transitions, to ensure patients remain out of the hospital unnecessarily. Hospitals and skilled nursing facilities will have to stay abreast of their measure count during the grading period, which we're currently active in, and everybody's efficiency is being graded now. So next year, your Medicare reimbursement will be determined based on efficiency measures of today's transition. So, reducing readmissions has proved to be difficult and not straightforward. Nonetheless, hospitals have been employing a number of strategies to reduce preventable readmissions. These include providing better and safer care during the inpatient stay, such as reducing the risk of infection, paying more careful attention to patient medications, seamless discharge planning, and improved communication with patients and caregivers regarding follow-up care, and improving care transition through better communication and collaboration with other community providers. Many hospitals and skilled care communities have already chosen partners in the delivery of spectrum that can show evidence of reduced rehospitalizations through collaboration and delivery mechanisms from one care setting to another. If strategies have not been taken place by your hospital or your skilled nursing facility, it's not too late. Even though performance has been accounted for previously, good news, like I said earlier, it's not going to end anytime soon. So quality assessment and performance improvements need to start now. You must find a champion care partner to ensure their goals are your goals. A like-minded care partner who will remain transparent, accountable, and sees themselves as an extension of your service, because they are. Their outcomes are, in essence, your outcomes. Their performance will dictate your reimbursement. As you can see, accountability measures doesn't just apply to the hospital. Did the patient see their PCP? or the primary care physician or enter an urgent care setting 3 days prior to a hospital admission? If so, new penalties are in discussion at CMS to hold the PCP accountable for care delivery. They, too, will be held responsible for outcomes, just like the hospital. Skilled nursing facilities and home care systems are. Medicare will continue to adjust spending until every unnecessary cost is eliminated to ensure funding is available for the next 18 years. Boomers are turning 65 at a rate of about 8,000 a day, according to AARP. And everybody wants to ensure there's coverage for those that have already invested. Value-based purchasing will have increased scores from 2013 through 2015. Each can be good news or bad news, depending upon the processes, your partners in care delivery, and your outcomes for improvement. The final score at the end of 2016 will determine which hospital systems receive financial reward. Those with the best scores win. To add to the performance weights, 3 diagnoses are heavily being watched: MI, heart attack, PN, pneumonia, and CHF, chronic heart failure. These 3 hold a tighter and higher readmission rate, therefore an increased readmission adjustment factor has been assigned. There's some good news. A recent study at Yale University, researchers identified 6 strategies that were modestly successful in lowering readmission rates for patients with CHF and heart failure. These included partnering with community physicians, partnering with local hospitals, having some home health nurses reconcile medications, arrange follow-up appointments with PCP prior to discharge, sending discharge papers to the patient's primary care physician, and assigning staff to do follow-up on test results after discharge. Hospitals that implemented more and more of these strategies had substantially lower readmission rates. Another approach, and one that I personally like, is, and it's been shown effective in reducing readmissions, is Project RED, and that stands for Re-Engineered Discharge. It was developed by researchers in Boston University Medical Campus, and 2 key features of Project RED are a nurse discharge advocate assigned to follow a patient throughout the discharge process and production of a simple after-hospital care plan. It's a beautiful thing. Home health services are vital in success in seamless transition from hospital to home to rehab to home. And this partnership has shown to be successful in decreasing hospital use, as well as combined emergency department visits and readmissions within 30 days of discharge by about 30%. Those are significant numbers. The takeaway is that many hospitals are in trouble here. There are certain diagnoses they can't perform well, or they can't lock in reimbursement to cover the costs of taking care of these high-risk patients. We see the impacts this has on the hospital. In many, the length of stay is shortened, and an increase to transitional patients to rehab for therapy at either a skilled nursing or outpatient with higher risk of rehospitalization rates. Doesn't mean that they're going to rehospitalize, it just means there's an increase to the shorter length of stay. We see rehab's length of stay anywhere between 18 and 29 days, and patients aren't quite out of the woods with chronic illness, especially a patient with several diagnoses that are long-term or chronic, CHF, COPD, MI, and then throw on top of it comorbidities that, exacerbates the situation. Now with CMS's approval on a 2-midnight rule that just happened within the last 30 days to activate the Medicare days, the skilled nursing facility must get smart and enter a relationship with a hospice and home care to ensure these chronic high-risk patients are being released to a home health company that is tracking these acute diagnoses, that they are held accountable for the delivery of care, and has a high-level engagement and a sense of urgency. Then you're ahead of the game. You will need to outperform other providers to ensure your patient is not returning back to the hospital. And more good news, Medicare is very likely in the near future to consider all health care conditions when it calculates penalties for readmissions to the hospital. So I like this graph. It shows kind of, again, I'm a picture person, so this kind of shows where we're at in the spectrum. If a patient has a physician appointment 3 days prior, has lab work or test run, and unfortunately, let's say, a COPD patient goes and sees a PCP to increase or to adjust her nebulizer or inhaler or anything like that. And the physician is doing a routine medical adjustment, and there's no hospital engaged, but the patient ends up going to the hospital 3 days later because she develops pneumonia. Guess what? Under the new rule in 2015, the physician is going to be held accountable because he did not identify symptoms of that pneumonia during that 3-day stay or the visit 3 days prior. Following that inpatient stay, you have several additional benchmarks within, and it could be up to 90 days, we're not really sure, but currently it's 30 that the hospitals are being held accountable for. So they go into the inpatient stay 5 days, are discharged to a rehab. Rehab enters 12 days, 15 days for PT and OT and possible RN. Patient's still recovering from bronchitis, and the patient goes home. If they go back to the ED, the physician, the hospital, and the skilled nursing facility will be penalized. So that's a clear indicator of kind of what this looks like overall. Hospitals that rank the lowest performing 25% with regard to the HAC will be paid 99% of what they would have been paid under the DRG in 2015. So significant reduction in reimbursement. However, there is some good news that if they do well, they can get that money back. So the writing's on the wall. It's imperative that skilled nursing and post-acute care become one seamless delivery system, as 100% of the rehab's referral are directed from the hospital. So if you look at the rehab in a skilled nursing facility, 100% of their referrals come from that hospital. And a partner in care that can solve the readmission issues a hospital is having will always carry more weight than the best marketing person carrying in a lunch or tchotchkes or pens or sticky notes for the discharge team. Strategically, well-planned outcomes are not by chance. They are by investment by all parties sitting at the table. So the Centers for Medicare and Medicaid Services have established a Medicare Shared Savings Program. And that's it's an amazing, out-of-the-box kind of thought. It's to facilitate coordination and cooperation among providers to improve the quality of care for Medicare fee-for-service beneficiaries and reduce unnecessary costs. Eligible providers, hospitals, and suppliers may participate in the Shared Savings Program by creating or participating in an account care organization, or an ACO. With the reduction of reimbursement, you're going to see ACOs high on the rise. They're an accountability care organization. It can be a group of doctors, hospitals, home health, skilled nursing, other healthcare providers who come together voluntarily to give coordinated high-quality care to the Medicare patients they serve. Coordinated care helps ensure that patients, especially chronically ill, get the right care at the right time with the goal of avoiding unnecessary duplication of services such as labs, tests, anything, and preventing medical errors. Many home health agencies have already secured ACOs with PCPs and skilled community settings where transparency on the delivery of services and outcomes are regular discussions. When an ACO succeeds in both delivering high-quality care and spending healthcare dollars more wisely, it will share in the savings it achieves for the Medicare program. If you want any information regarding an ACO or how to start one, there's information under the CMS.gov tab under Innovation Center tab, and you get to watch a brief video and determine the worth of these partnerships for your agency. It's very out-of-the-box thinking. I like it. On January 31st, 2013, the Centers for Medicare announced that the healthcare organization selected and to participate in the Bundled Payments Care for Improvement Initiative, an innovative new payment model. And under the Bundled Payment for Care Improvement Initiative, organizations will enter into payment arrangements that include financial and performance accountability for episodes of care. These models may lead to higher quality, better and more coordinated care at a lower cost to Medicare. Each participant would receive a reduced fee for service while providing better outcomes and efficiency to patient care delivery. The ideal is that with accountability and streamlined processes amongst all parties within the continuum, completely reduced rehospitalizations and the likelihood of future occurring. As a result, incentive monies are then earned. Many skilled nursing facilities and home health have already partnered and embraced bundle payment agreements with CMS to ensure long-term viability and, of course, reduce rehospitalization rates. Again, information is located at cms.gov. Okay, so what's this accountable partners piece? What does that mean by erasing silo care from patient care coordination? Accountable partners remove the silo effect because the patients are falling in between individual silos. The handoff, the 3 days post-discharge from the hospital or the skilled nursing facility is the highest bounce back time. So if you erase that and care coordinate and transition that patient seamlessly, partners understand and that each of them hold each other accountable within the care setting of the patient to deliver care in a way that is not to send the patient back to the hospital for any unnecessary reason. So you need to partner with an agency that understands this, gets it, how to get the patient back to the skilled nursing facility versus an acute care or the hospital for non-emergent need, and to avoid a hospital stay. Involving home health and the PCP prior to the discharge, getting ancillary services such as DME and non-medical assistance or palliative care in at the beginning prior to the discharge, sometimes at the beginning of the admission of the hospital or the rehab. It's one provider of care. We have to eliminate the idea that all of us run independently of each other, but we are all one service. Why? Because it's one patient, and that's the right thing to do for the patient. We should be handing the patient off to the next continuum of care, and if there is any decline, they would just go back a step to that prior service director. Other accountability factors for these groups is monthly meetings at the very minimum to discuss successes, to discuss opportunities to improve. These are key steps to reduce the likelihood of unnecessary readmissions. As a home health administrator, the best a patient looks is the day of discharge from a rehab, just like a shiny penny. They're all dolled up, they're in their wheelchair, they got their nails painted, they're going home, they're excited, they don't need home care, right? All the home cares are nodding and they're laughing because they get what I'm saying. These patients feel so good, they don't need us. And once home, guess what? Their success at transitioning will directly define your agency. If the patient jumps back to the hospital because of a fall, doesn't matter if it's DME related, it doesn't matter if they didn't stop and get their medications, it doesn't matter if the caregiver wasn't timely, it will reflect poorly upon us and the skilled nursing facility and ultimately the hospital, which will impact their reimbursement. So choosing a home health that understands and can implement, those are the key words, the necessary steps to ensure patient is safe at home, medications, proper education, tools, services, transportation, supplies for care, like wound care, for example, and manages with the PCP and the facility they were discharged from, gets to take care of the hospital patient. Those that believe that their service is an extension to the quality and commitment that the skilled nursing facility and the hospital has, gets to take care of the patient. Those that see each other as a referral or that they're, quote, just providing a visit nurse or therapy won't be here in 2015. We will not survive the new model of commitment it takes to ensure outcomes are delivered well. You can already see this take place here in the Denver market with home cares closing. It's very sad. So some of the things that physicians are also being held accountable, again, penalty and reward, that's how it works. TCM. TCM is a time spent coordinating care for patients transitioning from the hospitals, the nursing homes, skilled nursing facilities back to the community. So this is a billable charge. So any physician, PCP, anybody doing a follow-up face-to-face appointment, they can get an additional fee for care plan oversight and TCM, and they can bill those hours just like an attorney to ensure that they are doing their job, because that's what Medicare wants them to do. If you're not doing your job and you don't have a face-to-face and you didn't do the quality work, you don't get to manage that patient and you will get fined if the patient goes back. If you are managing your patient, we will pay you for taking that additional hour to, med reconcile and communicate with a home care nurse. These are vital. PCPs are vital in the success of the transition care from SNF to home. They must acquire a face-to-face appointment within a patient within 30 days, or the home health must discharge. It makes it very, very challenging. And honestly, it forces everybody in the spectrum to take accountability of these people and step up and manage their patients better. So some of the problems that we find with communicating with physicians, and as any good home care can attest to, is the patient transition to the home is not, quote, just a discharge. The physicians need to be involved. Thousands of home health agencies admit patients daily. These agencies that have a full understanding of the new delivery of care will slow down their transition process. We require better and accurate information at time of referral. The PCP is vital to the success of this, so we must get a verbal order at time of admission, or guess what? We can't admit the patient, right? So many times, hospitals receive inaccurate information from the patient regarding the PCP. Wrong. I haven't seen this patient. They say, I saw this doctor. He's my doctor. And we call the doctor, and she goes, I haven't seen him since 2001. So that's a good example, So we have to have a correct information at the time of the referral. Or in many times, there is no PCP assigned. Home care can help fix this. Believe it or not, a good home care will sit and identify a possible PCP for this patient without any need, without one, or generate a time to come back and see that PCP or clarify to find who the correct PCP is. And if they're a specialist, another call will be happening to that physician to ensure, are you the one who's going to be managing this patient? We're going to admit this patient on for cancer, and I'm going to get the oncologist to follow this patient if they're going to be the one managing the signs and the symptoms and all the orders. That's the correct thing to do. That takes additional steps. That requires a commitment and seamless communication. No more faxing in the midnight hour to come into the office to find a vague information, H&P, and possibly a face sheet. We need to dig down and really determine what level of care are we going to start this patient on. Do we have the correct PCP? Have we informed them that they are coming on to home care? Have we coordinated the transition from the hospital or the rehab seamlessly, and is there a plan in place? A great home health will set up transportation, will have med reconciliation completed within 1 day of the admission, and a follow-up PCP appointment within 3 days of the admission into home care. Upon the first appointment, PCP would receive a scorecard regarding patient activation and engagement of their medication and management of chronic illness, so all parties are involved with the level of care being provided by the home care, as well as how successful the patient is going to be in the home setting. PCPs can use this information at their face-to-face and, of course, subsequent appointments to ensure activation is high and safe. Great example. This is there's thousands of agencies across the state of Colorado, possibly even outside of this call, non-medical as well as home care. This is just Angel's Care Scorecard. I'm sure there's other versions out there. Ours begins in the skilled nursing facility, or if they are bypassing the skilled nursing facility, they start at the time of the referral. We start teaching the patient about their chronic health illness prior to the DC from the SNF, then transfers home with the patient where the RN then adds to it on the day of admission. So there should be a record of blood pressure, weights, education, any problems, any challenges we're finding with the patient. And then this goes to the PCP appointment, so the PCP can reconcile meds and see, oh, this patient just got a new heart medication. They're tolerating it well, no edema, no side effects. That's fantastic, because it would be noted in here, as well as a call would be happening by the RN to the PCP. So does the CHF patient have an unexplained increase in blood pressure or weight? Did the home health deliver a scale at the time of admission and start education regarding the new heart medication given to the patient? Does the patient understand when to take it? With food? On an empty stomach? What side effects is going to make them run back to the ER setting? A great home health agency understands that education is never ending and patients are worth the time it takes to save their life with this valuable information. Great tool, underutilized a lot. Other resources especially many skilled nursing facilities, have been trained on PAM, Patient Activation Measure. And what it is a tool that is unidimensional. And that's a lot of big words here, but honestly, we're just identifying the patient's activation and how engaged they are. It is patient perception. So the caveat is that the patient is going to say, yes, yes, I'm engaged, and we can show evidence that the patient truly understands their level of chronic illness and that they're trying to maintain it, and they're taking active measures to, document their diet, document their medications, document their weight, take their blood pressure, stay on a time with their appointments. And so a good PAM indicator will identify if this patient has the ability to transition home independently and remain successful, or if it's going to require a lot more education from the skilled nursing to the home health setting. And sometimes the PAM activation measure, once the skilled nursing facility does it, and then the home care goes and does their scoring, it might be off a bit. The 2s and 3s, I think, are the most volatile to watch because they are depending upon if they're in a skilled nursing facility, they have CNAs that will help them get dressed and help them shower, and their meals are prepared. And when in the home setting, they might have 400 feet of tubing to their O2 little yippy dogs, piles of magazines up to the sky, and it may be a bit different with safety and seeing how active they are in their own health care setting and what poses a challenge to their success. So those are the things that home care really does implement with the PCP, with the SNF, as well as a hospital to ensure that we're all speaking the same language. So if somebody who's scored a 2 is considered moderately engaged and is discharged, it's going to be risky. Having a partner in care is vital to know what the score means and what processes they have to put in place to ensure increased engagement by the patient. That's really the key here. That's just one tool. Another tool, I really am a fan of this one as well, is LACE. It stands for Length of Stay, Acuity of the Admission, Comorbidities, and Emergency Department Visits within the last 6 months. As PAM is really identifying patient engagement per patient perception, LACE is more data-driven. It's looking at, did the patient have a prior discharge within the last 6 months? How many times have they gone to the hospital? How many hospitals did they go to? So it's factual. And a great example of this is the Reddington Fairview General Hospital is a 25-bed critical access to independent community facility that provides health care for more than 30,000 residents living in rural Somerset County, bordering the Canadian border. They initiated and implemented a LACE assessment, and they had nothing but positive outcomes. By implementing LACE, they identified high-risk patients with target interventions. They had listed interventions achieved. They maintained the goal of providing at least 95% of HF patients with all recommended procedures and assessments in the Measure of Ideal Care bundle for 13 out of 15 months during the initiative. That is huge because it's data-driven. You can't really argue with data, and you're really encouraging, you're looking at your process improvements at your hospitals, identifying patients and why they're coming back, and then you have an automatic drill down. The only issues that I see with some of the LACE is that the skilled nursing facility and the home health really need to be educated on the scores because there's several different scores. They range from 1 to 19. They predict the rate of the readmission or death within a 30-day window. So they calculate it by the concurrent review, RN case manager's involvement. They enter it in the patient's chart with high visibility, sometimes right on that data sheet. Okay? And it says patient with LACE scores, and they put a number there. Like maybe it's a 14, maybe it's an 8, whatever. So when they have a score between 10 and 12, we can anticipate they have a high readmission rate. And you get an automatic referral to the care transition intervention or whomever the hospital is choosing to transition this patient seamlessly. Education starts at the hospital. Home health or rehab likely to be part of this transition model because they understand they're going to come back. So we have to identify those participants through these scores and understand what that means.
Maria, this is Kristen. I hate to interrupt, but you've got a little over 5 minutes left.
Oh, I'll fly. Thank you. Appreciate it. I can get going, can I? Interact is a quality improvement program designed to improve the early identification, assessment, and documentation. Interact is widely used in the skilled nursing facility. Great Home Health has already been trained on Interact, even though Interact has not developed a home health tool, but we can at least speak the language, as I'm sure a lot of other home cares can as well, to discern where the patient is going to go back to the hospital. Again, be proactive in pro-planning for upcoming proposed measures. You need to have tracking measures and tools that not only identify 30 days, but 90. These are tools in your survival kit. I love tracking. I'm kind of a nerd. But the Advanced Excellent Tracking Spreadsheet, it's free. You can add columns to it. You can leave it alone. But it's a disease diagnosis spreadsheet, like an acuity or PAM, so you can have a secondary model. Outcomes tracking tools, Interact tracking program, hospitalization or rehospitalization log, and then a discharge follow-up plan. This is an example of the Advancing Excellence Tracking Spreadsheet I was just talking about. You need to have thick skin if you're engaged in an ACO or an outcome or a preferred provider even, because you're going to have uncomfortable conversations regarding why the patient went back, and it may not be something you can manage. But you need to find a partner in care that has proven outcomes, proven to reduce rehospitalization rates. Some of the disease management programs that most home cares provide is education, and it needs to be proven, and it needs to initiate prior to the discharge from the hospital. Triggers. This is great. A lot of people don't understand. They think PT, OT, and that's it, or CNA. We're doing a lot of non-med. We don't do non-med, but my point is that there's a lot more, and it's symptom management across the spectrum. It doesn't have to have a major diagnosis that's going to send them back. In fact, most of them go back for a UTI, for any reason, pneumonia, sickness, wound care. If there's weight loss or gain, patient uses the ED. Here's a great one. I like this one. When the acute care is the PCP, because the patient can't keep their appointments, they need home care. Any kind of change of condition preempts a referral. So the takeaway, you need to choose a home health agency with patient-centered programs that already have this in place. One that can show positive outcomes, can deliver a progressive and unique patient care program that will have a dramatic and positive effect on your discharged patients. So choose wisely. Hopefully I've shed some light on how home health is the solution, or a great part of the solution, same with hospice and palliative care, for readmission issues and improving outcomes. There are literally millions of articles on the web that will reinforce the new processes of discharging patient home seamlessly with home health. I appreciate your time. Hopefully you have been ignited with a sense of urgency to implement some of the strategies to move the needle. Our time is up, but would like to offer a few moments for questions. If you need to leave, you may reach me for any questions at 303-752-9494, or you can reach me at maria.oren@angemarcompanies.com.
Thank you so much, Maria. And again, anyone who didn't get that contact information, you can go ahead and email us. The email information is on the Healthy Transitions website, and I can get that information to you. Now, as we're waiting for some questions to come in, this has been an amazing presentation. Thank you so much. Could you tell me a little bit about what you at Angels Care have done to really break down some of those silos, and what you guys are specifically doing to build bridges with other providers?
Well, I'll be very frank. It's not a secret. I think a lot of home cares are doing the same thing. But what we do is we meet monthly with key hospitals that we are accountable for caring for their patients. We meet also with entities such as South Denver Care Continuum, which is a phenomenal organization, and it is not a marketing, it is not a networking group. It is really, truly those invested in taking care of seniors to better inform and educate the partners in care of delivery, that we're all speaking and using the same language. If you want information on how to join or any interest, there's no cost, like I said, to South Denver Care Continuum, just let me know. Also, the other pieces that we do is we're very conscientious about care delivery, and we over-communicate to the PCP. Those, I think, in all home cares are nodding. I think those are sometimes the hardest and challenging, is to get another physician engaged. I think that will change in the next year, specifically with the penalties But for the time being, that's our challenges. I think hospitals get it. I think skilled nursing homes get it, and rehabs and such. Definitely home care gets it.
Okay, just comes down to building those bridges. We've got a comment from Marion Boxer.
I know, I saw that. I'm so excited.
Going pilot testing for home health and projected to be released mid-2014. That's wonderful information. I was not aware of that. I hadn't heard anything about that, so that's really fantastic. Let's see here. Are there any other questions for Maria out there? We've got quite a few people still on the line.
And I'll be honest, this is heady stuff, but
it's complicated.
I wasn't really aware, and I was sharing this. I don't know where everybody's engaged at. Some people are like, yawn, this is really old, and we were very well aware of this, and some of it's brand new. So to eliminate any information is really shooting ourselves in the foot, because we're all still accountable at the end of the day for the delivery. That's the tough part, is getting educated quickly, because we're all running out of time.
Right. We're running out of time, and things are changing very fast.
Yes, they are. Yes, they are.
All right. Well, it looks like we didn't have any other questions. Do you have any final comments?
I think my takeaway for all participants is, the only thing we can definitely depend on is change, and that's the only true. That's the only thing we can count on, is that everything's going to change dramatically. And unfortunately, we are being scored every single day with every single discharge, every single readmission to the hospital, and it is vital that the skilled nursing facilities and the hospitals are engaged and understand and are acting as such with their patients' best interest in mind. Hospitals are closing. They're closing units because of the penalties and the weights that these carry. And that's sad. That's really, really sad. So what we have to determine as a home care group is how we deliver care is going to directly impact the scoring for the hospitals and the skilled nursing facility. That's, I guess, my takeaway.
Yeah, that's great. Thank you again. So thank you again, Maria, for sharing your expertise. I appreciate it. Thank you, everyone on the phone, for joining us. We hope it's been a valuable use of your time and that you've gained some information you can use to further your efforts in care transitions. This webinar has been recorded. We are going to have it up and available on the HTC website, again, healthytransitionscolorado.org. It should be up in the next couple of days, and you can feel free to review it at your leisure. I hope you will join us next month. We're going to be talking with Katie Lewandowski over at the Colorado Hospital Association about the results of the Project Red initiative that just wrapped up in December of 2013. They've got some very exciting results from that, and we're looking forward to having her come and talk about that project with us. So thank you very much, and have a great day, everybody.